طلبة المرحلة الثالثة، السلام عليكم ورحمة الله. نكمل بإذن الله الجزء الثاني والأخير من موضوع Concepts in Pharmacodynamics، والعناوين الأخيرة التي أخذناها في المحاضرة السابقة كانت Potency and Efficacy. Potency can be defined as the quantity of a drug required to achieve a desired effect, while efficacy is the maximum effect an agonist can achieve at the highest practical concentration. The efficacy will depend on number of drug receptor complexes that will be formed, which is related to the concentration of a drug at the receptor site and the intrinsic activity. The intrinsic activity is the ability to activate the receptor and cause cellular response, which means that when the drug occupies the specific site in the receptor, the intrinsic activity is the ability of this drug to modulate the receptor and cause a response. Here is a dose response curve, and again the drug concentration is on the x-axis and response of the drug is on the y-axis. First example is morphine. This is the shape of morphine. The EC50 for morphine is less than the EC50 mediated by pethidine, which means that morphine is more potent than pethidine, while for aspirin, for example, the EC50 of the drug is much higher than the EC50 of morphine and pethidine. Therefore, aspirin is less potent than pethidine and morphine. In regards to efficacy, both morphine and pethidine can cause the same maximum response. Therefore, both of them are equally effective. While for aspirin, the maximum effect that can be achieved even with high concentration, even with increasing the concentration, the maximum effect that can be achieved by aspirin is still lower than the maximum effect that can be achieved by morphine and pethidine. Therefore, aspirin is less effective than morphine and pethidine. In a clinical practice, the efficacy is more clinically useful than potency, since a drug with a greater efficacy is more therapeutically beneficial than is one that is more potent. The effect of drug concentration on receptor binding. Drug-receptor interaction is determined by the affinity of the agonist to the receptor. And this, you know that the agonist and the receptor can interact and present in equilibrium with the drug receptor complex. Increasing the agonist concentration should increase the formation of drug receptor complex, and this is determined by a value that we call it equilibrium dissociation constant. The higher the value, the less the affinity to form the drug receptor complex. And this is what the other explanation for the affinity of the drug to the receptor. This can be determined by this equation, where dr is the drug receptor complex concentration and RT is the total concentration of the receptors and is equal to the sum of the free concentration of unbound receptor and bound receptors. So RT is the total number of receptors whether they are bound on or unbound, and D is the concentration of free drug that is not bound to a receptor, and KD, as we said before, is the equilibrium dissociation constant. And so as as the equilibrium dissociation constant increases, the affinity or the number of drug receptor complex will be decreased, assuming that the number of total receptors is constant. So in this figure, as the concentration of drug increases, there should be an increase in the number of bound drug to a receptor. And this is the mathematical conversion for the affinity of drug to a receptor. The relationship of a drug binding to pharmacological effect. The affinity of an agonist for binding to receptors should be related to the potency of that drug for causing a physiological response. Here in this figure, we are going to correlate the affinity of different drugs. Let me show the pen so that it will be easy to clarify the results. So here we have different drugs, and we are going to correlate the affinity of these agonists to binding to two types of receptors. These are alpha 1 receptors and beta 2 receptors, and correlate the affinity of these agonists with a physiological response. The physiological response that we are going to measure is bronchodilation and effect on blood pressure. The parameters that we are going to correlate are affinity as measured by the equilibrium dissociation constant. So a drug with the lowest value of equilibrium dissociation constant is the drug that has the highest affinity for the receptor. And for EC50, we are going to measure the physiological response by measuring EC50 again. A drug with the lowest EC50 value is the more potent drug to produce this physiological response. So in the first figure, in this one, we are going to correlate the affinity of different agonists. This one, for example, is phenylephrine, norepinephrine, epinephrine and norepinephrine. This is isoproterenol. So as we can see that phenylephrine has the highest affinity for alpha 1 receptor. Still, the physiological response that can be produced by binding of phenylephrine to alpha 1 receptor, this will not cause bronchodilation. And this makes sense because alpha 1 receptors are not commonly distributed in the bronchioles to produce an effect. And as you might know, that the binding of phenylephrine to alpha 1 receptor will cause smooth muscle contracture, increasing smooth muscle contraction and not relaxation. So it makes sense that even though that phenylephrine is highly bounded or has a high affinity to alpha 1 receptor, the effect that can be produced is negligible in terms of bronchodilation. And the same is applied to isoproterenol. Although isoproterenol has very low isoproterenol has very low affinity to alpha 1 receptor, and still in terms of bronchodilation it is very potent, but there is no correlation between affinity of a drug and the pharmacological response. On the other hand, if we move to blood pressure and the affinity of alpha 1 binding with the receptor to the physiological response that can be caused, which is an increase in the blood pressure, we can see that here phenylephrine is highly bound to alpha 1 receptor. At the same time, it can produce strong physiological response as it's shown by the low EC50 produced by isoproterenol. And then there is a direct correlation between binding of a drug or affinity of a drug to a receptor and the physiological response that can be caused, which is an increase in blood pressure. And for in the other case, if we correlate the affinity of these drugs with binding to beta-2 receptors and the physiological response, which is bronchodilation, also we can see that there is a direct correlation between the affinity of a drug and increasing EC50 or the physiological response produced. Here, for example, isoprotrinol is the drug with highest affinity to binding with beta-2 receptor, as it has the lowest dissociation or equilibrium dissociation constant with beta-2 receptors, and it has the highest effect on the physiological response, as it has the lowest EC50 value, which means that isoprotrinol can be bounded efficiently to beta-2 receptor, and at the same time it has the strongest effect on producing bronchodilation, as it has a low EC50 value compared with, for example, phenylephrine, which is a non-agonist of alpha-1 receptors, and phenylephrine has the lowest affinity to binding with beta-2 receptor, and at the same time the lowest EC50 of bronchodilation, because it cannot bind with beta-2 receptor that is responsible for bronchodilation. The opposite is true for the blood pressure efficacy. Also, again here, in terms of affinity to beta-2 receptors, there is no correlation between affinity to beta-2 receptors and the physiological response of producing or changing blood pressure. Okay, so here we will talk about intrinsic activity. The intrinsic activity of a drug determines its ability to fully or partially activate the receptors. As we said before, receptors are normally found in two forms. These are inactive and the activated form. And the conversion, as we said, between these two status depends on the equilibrium dissociation constant. For full agonists, a drug binds to a receptor and produce a maximal biological response. It stabilizes the receptor in its activated status, this form, and it is said to have an intrinsic activity of 1. So the full agonist will produce a full response and produce intrinsic activity of 1, which means that the binding of a full agonist to receptor will stabilize the complex of drug receptor in the activated form. While for partial agonists, a drug binds to a receptor and it does not produce a maximum biological response. It's said to have an intrinsic activity between 0 and 1. This means for partial agonists, they have the affinity to bind to receptors, but they cannot stabilize the drug receptor complex in the activated form. So some of the complexes will be in the activated form, but some of them will not be activated. Therefore, the response that we expect from partial agonist will not be the full response that we are going to expect from the full agonist. For inverse agonists, it binds to a receptor and reduces the effect. In this case, intrinsic activity is less than 0. For inverse agonist, it is the opposite as partial and full agonist. For inverse agonist, it will bind to a receptor, so it has affinity to the receptor, and the drug receptor complex that will be formed will be in the inactivated form, or will reduce the activity of the drug receptor complex, so keep the receptor in inactivated form, and then prevents the formation of physiological response. For inverse agonist, to understand the action of inverse agonist, we should keep in mind that even without the presence of an agonist. The drug can be found in both cases, which is inactive and activated state, even without the presence of an agonist. The drug, or sorry, the receptor can be found in two cases, which is inactive and activated form. So when there is an inverse agonist that can bound to receptor, this will shift the equilibrium in this direction. So this will decrease the number of activated receptors, and therefore the physiological response will be decreased. There is basal activity for all of the receptors, and this basal activity does not depend on the presence of an agonist to achieve this basal activity. It's just like a status, zero status for the equilibrium of physiological response, which means if a physiological response is produced by a specific receptor, there is basal activity for this physiological response even without the presence of agonist. So when there is an inverse agonist, this basal activity will be decreased as a result of shifting or decreasing the number of activated receptors and shifting the equilibrium toward this direction. I hope this is clear, and I will be happy to answer any question in regards to the clarification how inverse agonists and full agonists affect the equilibrium between activated and inactive form of the receptor. Okay, so let's again talk about the effect of agonist, full agonist, partial agonist, inverse agonist, and antagonist. As we said before, there's an basal activity for the receptors. This basal activity, we call it constitutive activity. Constitutive activity. As you can see here in this figure, there is sorry, there is a relationship between the concentration of the drug and the activity. So even though if the concentration of the drug is zero, there is a still constitutive activity, we call it basal activity for the response. In cases that we have an agonist, so increasing the concentration of the drug will increase the activity until we will reach the maximum efficacy activity or the response, in this case by the full agonist. So increasing the concentration will increase the activity and we will reach the maximum response. For partial agonist, as we said, the intrinsic activity of partial agonist between 0 and 1, which means that when the receptors is occupied by a partial agonist, this will not give the full activity of that we expect from that receptor. So in this case, even with increasing the concentration to maximum concentration, still the activity will not achieve the similar activity as that could be achieved by the full agonist. So the maximum activity that we can get is much lower than the activity that we can get from the full agonist. For antagonist, it will not change the equilibrium between activated and inactivated receptors, which means that there is no change. But for antagonists, they can prevent the interaction of agonist with the receptor, which means if an antagonist has bounded to a receptor, this will prevent the agonist from binding to a receptor, since the place for binding is already occupied by antagonist. We will come later to explain the interaction between antagonists and agonists and the effect of different concentrations of both of them. For inverse agonist, as we said, inverse agonist has an intrinsic activity of less than 0, which means that it will decrease the number of active drug receptor complexes and therefore affect the constitutional activity or basal activity, and then decrease the activity uh, with increasing the concentration of inverse agonist. Okay, so types of antagonists that we should keep in mind. We have three types of antagonists. First one is pharmacological antagonist, and this also includes different types. So for pharmacological antagonists, we have competitive antagonist, which means that the competitive antagonist prevents an agonist from binding to its receptors by occupying the place that is available for binding. And we have irreversible antagonist. In case of competitive antagonist, it is a competitive process. So the agonist and the antagonist compete with each other. Which one of them will win to occupy the available space in the receptor? This depends on the concentration of both of them. For irreversible antagonists, it is the binding of an antagonist with the receptor is irreversible, because the bond that will be formed by the interaction of antagonist with the receptor will be covalent bond, and the active site of the receptor will be fully occupied. That will not, even with very high concentration of an agonist, the antagonist will not leave the place and will stay in a place, preventing all other molecules from binding to the receptor, and thereby this will reducing the number of receptors available to the antagonist. For allosteric antagonist, this is interesting. For allosteric antagonist, this type of antagonism binds to a site, allosteric site, other than the agonist binding site, and prevents the receptor from being activated by the agonist. In this case, the binding site of the allosteric antagonist is different from the binding site for the agonist. Therefore, and still the antagonist still produce pharmacological antagonism by decreasing the activity of the receptor, but using a place which is not related to the place that the receptor agonist, full agonist, could interact with. We'll explain this with a figure in the next slide, inshallah. So here we just need to correlate between competitive antagonist and non-competitive antagonists and competitive antagonist in the presence of full agonist, and in the presence of agonist and antagonist, and agonist and antagonist at higher dose, and the presence of antagonist alone. So here we correlate the dose of agonist with the response that can be produced by the interaction with the receptor. So in the presence of non-competitive antagonist, which means irreversible, in the presence of non-competitive antagonist or irreversible. In the first case, there is agonist alone, so there is no non-competitive antagonist, so increasing the dose will increase the response, and we will get the maximum response. In case B, where there is agonist plus antagonist in low dose, and here it's not non-competitive, irreversible. So even with the highest concentration that we can get, we cannot achieve the maximum response, because some of the receptors are already occupied by a non-competitive or irreversible antagonist, and therefore even with increasing the competition, even with increasing the even when we achieving the highest possible concentration of agonist, this cannot displace the non-competitive antagonist from its binding sites and produce a response. Therefore, the maximum response that we can get is depends only on the free available receptors, and the free available receptor here is will not produce the maximum response. In case C, here we have agonist but with an antagonist at higher dose, which means that much more receptors are occupied by the non-competitive antagonist, and they are not free for the binding of an agonist to produce response. So even with increasing the concentration to maximum dose or concentration, the response is still very low compared with the case B and case A, where there is no non-competitive antagonist. So this is the case in the presence of non-competitive antagonist. In the presence of competitive antagonist, in case A, we have the drug agonist alone without the presence of competitive antagonist. As you can see, increasing the dose will increase the response. In case B, where we do have um, an agonist and antagonist at low dose, there is a shifting in terms of efficacy. So we do need higher dose of the agonist. So the start point is here. We do need a higher dose of the agonist to produce the same response that we get in case that we don't have an antagonist. So increasing the dose here will increase the response, and we can still reach the maximum response that we can get in the case of the presence of agonist alone without antagonist. This is because the increasing the dose of agonist will increase the availability of an agonist at the binding site, and this will displace, move away, or get rid of the antagonist from the binding site. And then as we said before, it is a competition. The one that wins is the one which has the highest concentration. So if we increase the concentration of agonist, it will displace the antagonist from the binding site and then take the binding activity, so taking the binding with the receptor and producing activity. Same apply in case C, where there is a agonist with a higher concentration of antagonist. Also, again, we do need more of the agonist in case of C than B, because we do have more competitor, which is the competitive antagonist. But again, the increasing the concentration of agonist will achieve the highest response, or the highest possible response from the interaction. Okay, so in this figure again, we just need to we confirm on the presence, on the effect of presence of agonist alone or agonist plus competitive antagonist, and then this will cause the will show the shifting in the in the effect of these agonists on the receptor. So in this case again, there is agonist alone, there is shifting because here we have agonist plus competitive antagonist. So we do need to increase the dose to produce the same effect, but we can get the maximum response as well. In this case, we have in this case of agonist alone, but in the presence of irreversible antagonist, we cannot achieve the highest response from the agonist itself, because the number of receptors available for binding are decreased due to being occupied by the irreversible antagonist. This figure shows the places where each of the each of the drugs can bound to a receptor. So this is a full agonist, this is competitive antagonist, this is allosteric activator, and this is allosteric inhibitor. Okay, so in case of there is a binding of agonist with the receptor, this will convert the receptor to the activated state and give a response. But in the presence of competitive inhibitor will compete with the agonist for the binding site, and there will be shifting in the drug receptor interaction. For the first case, where we have only A, which is the agonist, we still have this figure of dose response curve. And then if we add B, which is competitive, the figure will be this way. So we do need more of the agonist to displace the competitive antagonist from this binding site and then produce the same effect. But in case of C, with A and C, here we have allosteric activator, which means that the drug is bound to allosteric site other than the binding site of the agonist itself, and produce increasing the activity of the receptor. Allosteric activators are not agonists by themselves, but they can increase the efficacy of agonists by acting on different sites. So in this case, you can see from A and C figure, the efficacy has decreased. The efficacy has decreased because of the binding of allosteric activators with the receptor and converted to the activated form. In case of A and D, D is allosteric inhibitor. Also, it's bound to allosteric site other than the binding site of the receptor, and therefore decreasing the activity of drug receptor interaction. And we will get this figure again. We cannot reach the maximum response that we got from the binding of A alone or the receptor agonist alone. I hope this is clear. Okay, so the second type of antagonists is the physiological antagonism. The antagonism is a different antagonism that acts on the same tissue as the agonist, but combined with different receptors from those of the agonist to produce effects on the site that are opposite to those of the agonist. In simple words, for physiological antagonists, both of them are agonists. So they are different agonists, but then the effect that can be produced by these agonists is opposite in each other. An example of this is the adrenaline antagonizes the effect of endogenous histamine on blood vessels and bronchial smooth muscles when used in the treatment of anaphylactic shock. So anaphylactic shock is a clinical situation or deterioration due to the excessive release of histamine from mast cells due to allergy or something that produce allergic responses in the body. This will cause an excessive release of histamine inside the body. Histamine, as you know, can act as a bronchoconstrictor, where it causes bronchoconstriction, and it causes decrease in the blood pressure due to its effect on blood vessels, specifically like external blood vessels, where it produces vasodilatation, and this will cause redness in the skin and a drop in the blood pressure. So in this case, the effective treatment is by the administration of adrenaline. Adrenaline is known to be an agonist as well. So just like histamine is an agonist for increasing bronchoconstriction by acting on H1 receptors, and also by decreasing blood pressure. It acts by being an agonist. And adrenaline is also an agonist by activating beta-2 receptors in the bronchial smooth muscles. But the activation of beta-2 receptors in the bronchial smooth muscle will cause bronchodilation, which is the opposite of the action of histamine on bronchial smooth muscle. On the blood vessels, you know that adrenaline activates alpha-1 receptors on blood vessels and cause blood vessels and then cause vasoconstriction that antagonizes the effect of histamine on the blood vessels, and this way adrenaline acts as a physiological antagonist for the histamine. The third type of antagonism that we have is the chemical antagonism. In the chemical antagonism, antagonist interacts directly with the drug being antagonized to remove it or to prevent it from binding to its target. Example of this is the dimer caprol. Dimer caprol is a chelator of lead and some other toxic metals, and also we have pralidoxime. So dimer-caprol interacts chemically with lead and prevented lead from being to be toxic and activate or enters the body to produce physiological response, not physiological or toxic responses. Also, we do have pralidoxime, which combines uh, avidyl with the phosphorus in organophosphate cholinesterase inhibitors. So pralidoxime can chemically prevent or the organophosphorus toxicity by preventing the interaction with cholinesterase, and therefore it's commonly used as a treatment choice to prevent organophosphate organophosphorus compound toxicity by enhancing uh, uh, by enhancing the reactivation, chemically enhancing the reactivation of cholinesterase receptors. Quantal dose response relationship is another important dose relationship curve, which is important in pharmacology. Here, it's correspond to the relationship between concentration of drug or the dose and the percentage of individuals from a population that respond to this drug. Here at low concentrations, only small population number of population have responded to this concentration. Let's take an example. Let's assume that we have 100 individual, 100 patient, and we do need to find the antihypertensive effect of a drug. Let's assume that this drug is atenolol. Atenolol is a beta-1 receptor antagonist that is commonly used to treat elevated blood pressure or elevated blood pressure by acting on the heart. Anyway, so we have 100 individual with elevated blood pressure, and we wanted to measure the dose response relationship, the quantal dose response relationship for this drug. As we increase the concentration uh, of atenolol, the number of populations that respond to this drug will be increased. So on the first, at low concentrations, only 20 patients will respond to this concentration. Increasing the concentration, we will get that 40 individual or patient will respond to this concentration. At concentration 10, for example, here, we will see that 50 50% or 50 patient will respond from total of 100 will respond to this concentration. As we increase the concentration, the number of populations will be increased until we reach 100. So the drug concentration that can, or the dose that can produce pharmacological effect in 50% of the population is called ED50, or the effective dose 50. It's also a measure how effective the drug is in a population. This is called the quantile dose response curve, which is useful for determining doses to which most of the population responds. So we normally use a dose that is above ED50 to be sure that this dose will be effective in the treatment of specific situations. Okay. So we do have another pharmacological parameter, which is the therapeutic index. Therapeutic index of a drug is the ratio of the dose that produces toxicity in half of the population, which is TD50, to the dose that produces a clinically desired or effective response in 50% of the population, or the ED50. So the calculation of therapeutic index is measured by dividing the toxic dose in 50% of the population over the effective dose in 50% of the population. If the therapeutic index increased, this means that there is a huge difference between TD50 and ED50, and the drug is much safer to use. There is a big margin between ED50 and TD50. If the opposite is true, if the therapeutic index is low, then the TD50 is very close to the ED50, which means that the margin between safety and toxicity is very low. Let's see this example in which warfarin, which has a small therapeutic index, which means that the concentration or the dose that can produce therapeutic effect is much or very close to the dose that can produce unwanted effect or toxic effects for this drug. With increasing the concentration, we will increase the response. But then you can see here, if we wanted to achieve 100% response in the population, we have to increase the dose to a place where we can start to see an adverse effect or toxic effect, because the difference here between effective and toxic doses are very close. Another example, we have penicillin, which has a large therapeutic index. You can see here that even with high concentration, where we achieve the maximum response, there is still a gap between the effective and toxic doses. So for drugs, it is important to know whether the drug has a low or high therapeutic index, so that it's important to monitor plasma concentration and give the drug in appropriate doses to avoid toxic levels. And we get here to the end of this lecture and the end of the pharmacodynamic parameters in the Pharmacology 1 for third year. Please let me know if you have any question, and I will be happy to answer them. Many thanks to you.